Congenital middle ear anomalies can significantly impact hearing. Today, we'll explore the Creamer classification of congenital ossicular chain malformations, a critical tool for diagnosing and managing these conditions. First, let's briefly touch on the embryology. The malleus and incus develop from the first branchial arch, while the stapes arises from the second. Any disruption during this phase can cause malformations leading to conductive hearing loss. Now, let's dive into the classification. Group I, isolated ossicular anomaly. In this group, one or more ossicles, usually the malleus or incus, are malformed or missing, but the stapes and oval window are intact. For example, a 12-year-old patient presents with moderate hearing loss. Imaging shows a hypoplastic malleus. Surgical reconstruction of the ossicular chain, such as ossiculoplasty, can often restore hearing since the stapes is unaffected. Group 2, ossicular anomaly with normal stapes. This group involves more extensive malformations, often involving both the malleus and incus, but the stapes remain normal. In one case, a 30-year-old presents with significant conductive hearing loss. Imaging reveals fused malleus and incus, but a functioning stapes. Reconstruction with prosthetics can yield good hearing outcomes. Group 3, ossicular anomaly with stapes fixation. In this group, the stapes is fixed or malformed, leading to more severe hearing loss. A practical example, a 40-year-old patient experiences severe conductive hearing loss. Imaging shows a fixed stapes footplate. Here, stapedectomy or stapedotomy, followed by prosthesis insertion, may improve hearing, but outcomes vary. Group 4, anomalies involving the oval or round windows. The most severe category involves not just the ossicle, but the oval or round windows. Take a newborn with profound hearing loss. Imaging shows absence of the oval window. Surgical correction is challenging, and in cases like this, bone conduction hearing devices might be necessary. Understanding these categories helps clinicians develop targeted surgical plans, improving patient outcomes. The Creamer classification provides a structured way to approach middle ear anomalies and tailor interventions. Syndromes like Treacher-Collins syndrome or Goldenhar syndrome, where there are additional craniofacial deformities. Syndromes associated with middle ear anomalies include Treacher-Collins syndrome, characterized by underdeveloped facial bones, auricular malformations, and ossicular chain abnormalities leading to conductive hearing loss. Goldenhar syndrome is associated with facial asymmetry, auricular deformities, and various middle ear anomalies, including abnormal ossicles. Mobius syndrome can involve facial nerve palsy and ear malformations. Patients with congenital anomalies of the middle ear often present with conductive hearing loss, which is the most common symptom, ranging from mild to profound depending on severity. They may also experience facial nerve weakness or paralysis if the facial nerve has an anomalous course or is damaged during development, as well as recurrent ear infections due to eustachian tube dysfunction or middle ear anomalies. Diagnosis involves audiological testing, including pure tone audiometry and tympanometry, to assess the degree and type of hearing loss. Imaging, such as high-resolution CT scans of the temporal bone, can reveal ossicular abnormalities, middle ear cavity size, and facial nerve position, while MRI can be used to assess soft tissues like congenital cholesteatoma or facial nerve anomalies. Genetic testing can help confirm the diagnosis and guide management in cases of syndromic middle ear anomalies. Management includes conservative options like hearing aids for patients with conductive hearing loss who are not candidates for surgery, and monitoring in cases of mild anomalies or those without significant hearing loss. Surgical management may involve tympanoplasty to repair the tympanic membrane or middle ear structures, ossicular chain reconstruction to improve sound conduction, stapedectomy for stapes fixation, and cochlear implantation for patients with combined middle and inner ear abnormalities. Facial nerve monitoring is critical in surgeries where facial nerve anomalies are present to avoid nerve damage. Complications of surgical treatment can include iatrogenic facial nerve injury due to the anomalous course of the facial nerve, residual hearing loss despite surgical intervention, and recurrence of cholesteatoma if not completely excised. Congenital anomalies of the middle ear present unique challenges in diagnosis. treatment, and surgical intervention. A multidisciplinary approach involving audiologists, ENT surgeons, and geneticists is often necessary for optimal management. Early identification and intervention are key to improving hearing outcomes and quality of life for affected patients.